focus our talk on the EFAST exam, which is the Extended Focus Assessment with Sonography in Trauma. And basically, this is a exam that has been around since the 80s, and one of the first exams used in point-of-care ultrasound. And it was used to help detect fluid in the abdomen, so intraperitoneal fluid or even pleural fluid, pericardial fluid, and a pneumothorax. And we use this in the setting of trauma. It is best used in our sick patients, and what I mean by that is data is really positive in that when there's pathology creating hemodynamic compromise like hypotension in patients or maybe hypoxia, ultrasound is likely to pick those up. And so it's indicated in our blunt and penetrating traumas and even chest trauma patients, and again has a great benefit in our unstable patients. It does have some limitations that you can see here. For instance, if you see fluid in the abdomen, you can't necessarily tell if it's ascites fluid or blood. And it's not really good for picking up things like a hollow viscous injury. What I mean by that is a perforation of the bowel. Sometimes we can't get great images based on patient's body size or habitus. And there's some areas that we're not great at detecting bleeding or free fluid, such as in the retroperitoneal space. Our main views are seen here. We usually use six main views, and we look at the ribs between the ribs on both sides, and the intercostal view, looking for a pneumothorax. The subxiphoid view is used to look at the heart, and we look for free fluid around the heart or blood around it. And then the three other views, the right upper quadrant, the left upper quadrant, and suprapubic view, are generally used to look for free fluid in the abdomen. The probes that we generally use for this are the curvilinear or the phased array probe. Either are acceptable, and you'll see clinicians using both. The main view that we use here is the right upper quadrant view. It's probably the most synonymous view with the FAST exam, but basically what you're scanning is in the right upper quadrant in the midaxillary line near the inferior portion of the ribs, and you're generally having your probe marker facing towards the head or cephalad, as you see here. And our goal here is to look at the structures in the right upper quadrant. And we stress looking for the liver, the kidney, and we see the pleural space, which is right above this bright line here on the left, which is the diaphragm. And we look for fluid in this pleural space around the liver, or between the kidney and the liver as well, or even around the tip of the liver. So here's this kind of a still image for reference. And here's what you might see in a patient who has free fluid or blood in their abdomen in the setting of trauma. Again, we see the liver. We see the diaphragm coming in and out of view when someone breathes. We even see the ribs down here behind the patient with some shadowing. It's kind of lumpy, bumpy down here of shadowing, and the kidney. And then this black area between the two, between the liver and the kidney, is called Morison's pouch. It's a potential space. You shouldn't see fluid there, but in this patient you'd see a black stripe there coming to a point, indicating that it's free fluid, not within an organ. And that is what you might see in someone with a positive FAST or free fluid in the abdomen. So here's kind of still to kind of show what we're seeing with free fluid in Morison's pouch. Here's just another example of another positive FAST. Again, stressing the importance of looking between the kidney and the liver. There's shadowing here coming from the top of the screen, which is from the ribs. And as you scan towards the feet or caudal, you see free fluid on the liver tip, indicating that there's free fluid in the abdomen. The next view that we'll look at is the left upper quadrant. This is not all that different from the right upper quadrant, but what we're doing is we're looking here through the spleen to see the kidney and splenorenal space, and we look for fluid around the spleen, around the kidney, and in the area. And this is what you might see in a standard image. And so it's not ideal because you see ribs here, but I left this image to show you the importance of, we see artifact all the time. Ribs are in our way here, so you have to move the probe slightly, and we see the spleen up here in the top left. We see the kidney kind of coming in and out of picture here in the middle of the screen, and there you can see it well there. And you see again the pleural space here. And I should point out here that the head is off to the left here, and that the feet are off to the right. And by using our standard probe orientation of the probe pointed towards the head, we get this similar orientation every time. Generally, we're scanning with the probe marker towards the head or towards the patient's right in most standard imaging. Here's an example of what free fluid in the left upper quadrant can look like. Again, you see the spleen here up to the top. It's a little bit covered by some shadowing and darkness from the top of the screen from the ribs. You see the kidney off to the right, but you see this black anechoic stripe here indicating free fluid in the splenorenal space. And here's a still for reference. On both the right upper quadrant and left upper quadrant view, we also want to look in the pleural space. And once you get your views, you slide the probe up towards the head, closer to the armpit or axillary area, and you go up a couple rib spaces. And ideally what we're doing is looking for free fluid in the pleural space, so something like a hemothorax in the setting of trauma. And the image on the left is a patient who does not have free fluid in the chest, while the patient on the right does. It might be easier to show you the pathology first, but if I pause it here, what you see is the spleen, or actually this is the liver on this patient, and then the kidney. And then what you see is the spine coming all the way up here into the pleural cavity. And normally you can't see this because there's air in the way of the lung, because the lung is there, and the lung is a high reflector and doesn't allow you to see deep. However, because there's fluid here rather than lung, you actually can see the spine or ribs actually going up into this space here. Well, if you look at the image on the left, we have lung in the way, and we don't actually see that spine creeping up into the pleural cavity because there's air here. And because there's air there, we can't see the spine, which tells us that there's no free fluid. So this is actually normal. So the next view we look at is the suprapubic or pelvic view. Here we look usually in two planes with the transducer to the patient's right in a transverse view, and also longitudinal with the probe marker towards the patient's head. And this is what we would typically see in a normal patient. We scan with the probe marker low enough, you usually see the pubic symphysis. So this is shadowing again from bone, similar to what you would see in the ribs. And then just cephalad or towards the head, which is off to the left here, you see the bladder. And then you look for a black stripe below this, which we don't see, and which is good. But if there's free fluid, you would see a black stripe of fluid down here, which indicates free fluid in the pelvis. Here's what you might see on a female patient. You see a bladder. The pubic symphysis would be off to the right, and the feet are off to the right as well, and the head is off to the left. And then you see the uterus here, which you can follow down to the cervix and actually see the vaginal stripe. And here we look for fluid in two spaces, which is between the bladder and the uterus, or the vesicouterine pouch, or behind the uterus in front of the rectum down here, which is called the rectouterine pouch, or also known as the pouch of Douglas. On females, you might typically see a small amount of fluid there, which is not unusual, especially in a menstruating female. So here's what you might see in a positive exam. You see the bladder here, and then you see just inferior to the bladder or posterior in the patient or cephalad, you see free fluid in the pelvis. So this would be an indication of free fluid or potential blood in the pelvis in a patient who sustained trauma. Another view that we'll look at here is a subxiphoid view. So this subxiphoid view is what we use to look at the heart, and typically you'll have the probe indicator towards the patient's left here, but it also could be to the right. And again, we can use the curvilinear or phased array probe here. And we have to have our hand on top of the probe, and we have to push down slightly. It can be a little bit uncomfortable for the patient, but then we look for the heart up in the chest, and we scan through the liver. So we're actually using the liver as a window. The liver allows sound waves to travel through it quite well. So what you'll see in these next pictures is you'll see the scanning through the liver, and then we'll see the heart. So here's what you would see. So this is a picture of a heart from a subxiphoid view with a phased array probe. Notice it has kind of a pie-shaped sector. Here is the skin and abdominal muscles. Here's the liver that we're scanning through. And the first structure of the heart that we encounter, which is closest to the liver, right up against the diaphragm, is the right ventricle. So here is the right ventricle here, and here's the septum, and the left ventricle is on the other side. So if you can find out the structures, you can build out the rest of the heart. So this would be the left atria and the right atria here. And here's kind of that still image. Again, see liver, right ventricle, left ventricle, right atria and left atria. And when we're doing this in the setting of trauma, we're looking for fluid around the heart, so that would be around the pericardium. And if that was the case, you'd see a black stripe here between the liver and the heart, and in this case, you do not. Which is different from this case. This is a patient with a positive subxiphoid view, meaning that they have free fluid. So again, we're looking through the liver here. It's not as prominent in the last patient, but you see this black or anechoic stripe of fluid around the heart. You actually see it all the way around in front of the left ventricle, in front of the right ventricle, and on the other side of the left ventricle. And this is pericardial fluid. In the setting of trauma and hypotension, you would assume that this is potential pericardial blood. And here it is again. Apologize, this is actually should say right atria, but this is again pericardial fluid in around the heart, and so we think this is blood in this potential space. Here's just another example of what one might see. This is a little bit of an interesting view, but we're doing again a subxiphoid view. This is with a curvilinear probe. You'll notice that the probe the probe surface is much broader and not more, and still pie shaped, but doesn't come to a point. And here we're scanning through the liver. We see the heart down here, way down here, but in between you see this hyperechoic structure moving within some hypoechoic or black fluid, and that is actually a clot forming acutely in the setting of trauma, leading to a pericardial clot, which could potentially be very detrimental to this patient if not found quickly, as was found in this patient who went to the operating room and had this evacuated and did well. Last thing we'll go over is the intercostal or lung view. Here we are scanning with the probe indicator towards the patient's head. We're typically scanning near the mid-clavicular line, somewhere between the 3rd and 5th or 6th rib spaces, and our goal is to see the pleural line, or the space between both ribs, and we use this to look for a pneumothorax. Now, this isn't a comprehensive lung talk, but we start with this image where we see the probe on the surface of the skin. You see skin here, you see pec and intercostal muscles, and then you see rib with shadowing, so you can't see behind it, and you see another rib here of shadowing. And then you see this pleural line. This is actually the parietal and visceral pleura of the lung sliding back and forth as someone breathes. And because there's this shimmering, that actually tells us that there is no pneumothorax. This is normal. You expect the parietal and visceral pleura to slide past each other when someone's breathing. And you get this shimmering artifact, which we call sliding, and that's a normal finding, showing us that there's no pneumothorax. As opposed to this image, you see again, skin, intercostal muscles here, and then you see actual rib, and then you see the pleural line just below the ribs, and you don't see that same sliding. If you need to go back and forth, you can, but basically this tells you that the parietal and visceral pleura of the lung are not in contact, which tells you that there's a pneumothorax. Now, you don't know if there's just a small amount of air or a large amount of air, but if there's any air separating the lung and the chest wall, that tells you that there is a pneumothorax, which in the setting of trauma, if someone's hypoxic, this could be indication for an emergent chest tube. There's another thing I'd like to point out here called the lung point, and it kind of helps solidify this idea of lung sliding. And basically what this is, you see this patient here, you see skin, you see pec muscle and intercostal muscle, and then again you see rib here on the right and shadowing behind it, and on the left you see rib shadowing again and from the rib, and then here you see this pleural line. And if you look closely on the right side of this pleural line, you do see shimmering, and that's a slight movement there. And that is actually where the lung is in contact with the chest wall, so there's sliding. But if you look here on the left side, you don't actually see that sliding. And that tells you this is right where the lung dives away from the chest wall, indicating that this is where the pneumothorax kind of starts and ends. And this is 100% specific for pneumothorax, and indeed tells you the patient has a pneumothorax. Just to kind of summarize this last concept of lung sliding, as it's kind of difficult, this is a CT scan of a patient, and you can see this is the anterior chest wall, this is their lateral chest wall and posterior. This is the lung within the chest cavity, and this black area is where normally the lung should fill this whole space. However, this patient has a pneumothorax, and thus there is no lung contact to the chest wall anteriorly, but laterally there is. And so if you look at this, you can see that there would be no sliding because the parietal and visceral pleura of the lung are not in contact, thus they're not moving and sliding past each other, so you would see no sliding. While if you look posteriorly, you would see sliding as you would in the bottom left picture because the parietal and visceral pleura are in contact. But if you image right here where the lung slides away from the chest wall, you would get that lung point, which is why in the picture to the left you see lung sliding for a portion of that picture, but not here on the right.